For your patients with hard-to-control hypertension, are you struggling to achieve blood pressure goals despite treating with at least 2 antihypertensive medications? Uncontrolled hypertension increases the risk of death and stroke for many patients. Not all hypertension is the same. For many of these patients, you may want to consider a different pathway. Aldosterone may be to blame. Visit blamealdo.com to learn more.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hi, CardioNerds. We are so excited to have you join us as we continue our advanced therapy series today with a deep dive into the world of left ventricular assist devices, or LVADs. We are incredibly honored to be joined by not one, but 2 distinguished guests today who are both experts in the field of transplant and VAD, Dr. Jeff Teuteberg and Dr. Mani Daneshmand. Advanced heart failure transplant cardiology is a team sport that requires both heart failure cardiology and cardiovascular surgery, which we're thrilled to have reflected in our series. But first, let me introduce Jenna Skowronski. Jenna is our CardioNerds Heart Failure Council Chair. She completed residency, chief residency, and cardiology fellowship at the University of Pittsburgh Medical Center, where she's also completing her master's in medical education. She wrapped up her advanced heart failure and transplant cardiology fellowship at Vanderbilt before joining University of North Carolina as faculty in heart failure and director of cardio obstetrics. Welcome, Jenna.
Thanks, Shazli. I'm so thrilled to be a part of this series, which is near and dear to my heart, and also to have both Dr. Teuteberg and Dr. Daneshmand, true leaders in their field, joining us for this episode. Our episode lead is Dr. Josh Longinow, who completed his residency at Cleveland Clinic before making his way to Pittsburgh for cardiology fellowship at Allegheny General Hospital. Josh is entering his 3rd year of general fellowship and will be applying for advanced heart failure fellowship. Welcome, Josh.
Thanks, Jenna. As someone who's passionate about advanced heart failure and transplant cardiology, and specifically advanced therapies, I could not be more thrilled to be part of this important series and learn from our esteemed faculty today. I'm honored to introduce Dr. Jeff Teuteberg. Dr. Teuteberg completed medical school, residency, and fellowship at the University of Chicago in Chicago, Illinois, before he went on to complete advanced heart failure and transplant cardiology fellowship at the Brigham and Women's Hospital in Boston, Massachusetts. Dr. Teuteberg was also president of the International Society of Heart and Lung Transplantation in 2018, and he's currently professor of medicine and section chief of advanced heart failure transplant cardiology at Stanford University. Welcome, Dr. Teuteberg. We're so glad to have you here and learn from you.
Thanks, Josh. Great to be here. And congratulations on the whole cardio nerd phenomenon. It's really impressive to see it from afar. You guys have really come a long way. It's really amazing.
Thanks so much, Dr. Teuteberg. It's also my pleasure to introduce Dr. Mani Daneshmand. Dr. Daneshmand completed his medical training at Albany Medical College in New York. He went on to complete his residency and fellowship in general surgery and cardiothoracic surgery at Duke University Hospital. He's now at Emory, where he serves as the Director of Heart and Lung Transplantation, MCS, and ECMO programs. Welcome to the show, Dr. Daneshmand. It's such an honor to have you join us today, and we're so happy to have your surgical perspective.
Thank you very much for inviting me, Jenna, and I'm excited to be here to chat with y'all. This is, believe it or not, my first podcast ever, so I'm excited to be participating in this for such a great thing, and excited to chat with Jeff about a topic that's really near and dear to my heart.
Wonderful. We're so thrilled to have both of you. Okay, so to give our listeners a roadmap about what to expect in this episode, we'll start with a discussion around the history and mechanics of durable LVAD, follow that up with candidate selection for these devices, and then round out the discussion with surgical considerations to take into account. With that, Josh, take it away.
Awesome. So I thought we'd begin today's episode by joining our advanced heart failure team as they're seeing a few patients in the outpatient VAD clinic. We have 3 patients. First up is Miss Hartware. She's an 80-year-old female. She has a history of non-ischemic cardiomyopathy, and she underwent HVAD implantation in 2015 as destination therapy. She has stable NYHA class 3 symptoms and currently is on a medical regimen consisting of warfarin, aspirin every day, carvedilol 6.25 BID, and valsartan 40 BID. She had a recent hospitalization for a GI bleed, and you interrogate her device today and shows the following settings: a speed of 2,700 RPMs, flow of 5 liters, power of 4.2 watts, and her INR checks out at 2. Next door, we have Mr. Axial Flow, and he is a 74-year-old male who has ischemic cardiomyopathy and underwent HeartMate 2 placement in 2013 as destination therapy. His post-op course was almost immediately complicated by an ischemic PCA stroke, from which he has some mild residual left-sided weakness. He has stable NYHA class 2 to 3 symptoms and is currently on medications including aspirin 81 milligrams daily, bumetanide 2 milligrams every day, and warfarin. His INR is 2. We review his device and his settings show a speed of 9,200 RPMs, a PI of 4.3, and a power of 5.5 watts. Finally, we have Miss Centrifugal. She is a 68-year-old female with a history of ischemic cardiomyopathy, and she underwent HeartMate 3 implantation in 2021 as destination therapy. She endorses stable NYHA class 1 to 2 symptoms, and she's on a medical regimen of Entresto 97103, Carvedilol 6.25, rosuvastatin, and warfarin. Her device shows settings of speed 5,300 RPMs, PI 3 to 4, and power of 5 watts.
I am particularly fond of those case names. Thank you, Josh. So, despite improvements in medical therapy, we know that the advanced heart failure carries a pretty dismal prognosis, with mortality rates up to 50% at 1 year. Although heart transplant has long been considered the gold standard for end-stage heart failure, organ availability is limited, and there have been some exciting data in the VAD space regarding long-term mortality. The advent of continuous flow left ventricular assist device, or LVAD, has been revolutionary in the treatment of advanced heart failure, and we have seen significant advances since the first reported LVAD in 1963 to the first FDA-approved devices in the early 2000s. So, Dr. Teuteberg, can you provide the audience with just a brief overview of LVAD therapy, how these devices work, and maybe you can briefly explain the basic configuration of an LVAD and how it functions? So I'm thinking about inflow, outflow, driveline, power source, that kind of thing.
Yeah, sure. Happy to. Yeah. So, I mean, I think that although I wasn't around to see the bad old days of 1963, I did see the bad old days of the original pulsatile pumps when I was in training. So the era of continuous flow pumps really revolutionized mechanical circulatory support. And I think brought it almost, I think, to a par with cardiac transplantation, particularly sort of early survival. But like you said, the pump itself has three components: the inflow cannula, the pump itself, and the outflow cannula. So it used to be that the inflow cannula was actually a cannula, meaning that you put it into the apex of the left ventricle and it pulled blood through that to the pump itself. But nowadays with the HVAD and with the HeartMate 3, the inflow cannula is sort of built into the pump itself, so that when you put the inflow cannula into the left ventricle, the pump actually sits intrapericardially. So much easier to implant. So the HeartMate 2 does still have an inflow cannula, so the pump sits a little bit lower than that. It sits pre-peritoneally rather than inside the thoracic cavity. But be that as it may, the outflow cannula leads from the pump to the aorta, the ascending aorta, kind of above the sinuses of Valsalva. The pump itself really only has one moving part with the continuous flow devices, and that's the impeller. And that's the thing that moves the blood. And for all three of these devices, the HeartMate 2, the HVAD, and the HeartMate 3, the impeller is spun magnetically, meaning there's nothing really touching it. It's rotating in a magnetic field. So the HeartMate 2 was an axial flow pump, meaning that the blood flowed in the same axis that the impeller was turning. You can think of sort of like a corkscrew spinning, and the blood was flowing in the same direction. And with the HeartMate 2, there were actually a couple of mechanical pivots sort of before and after where the impeller was to keep it from translating back and forth. And that was actually one space that you could get some heating and some friction and clot could form. And that was a kind of an Achilles heel of the HeartMate 2 pump itself. With the HVAD and the HeartMate 3, there are centrifugal flow pumps, meaning that the blood is flowing perpendicular to the axis that the pump is spinning, and then it's sort of spun out from there and accelerated out the outflow graft. The big difference between the HeartMate 3 and the HVAD are a couple sort of maybe minor things, but I think ended up being important in terms of their clinical use. So the pump is still spun, the impeller is still spun magnetically in the HVAD, but what keeps it from kind of banging up and down against the housing in which it's spinning are what we call hydrodynamic bearings. And that's basically a plasma layer. And so that's all well and good, but the gap between the impeller and the housing is pretty small. So small bits of clot that might get sucked in from the ventricle or from the atria can get caught in there and cause the pump to have a thrombus. Whereas the HeartMate 3 is not only spun magnetically, but it's suspended magnetically as well. And the sort of practical implications of that is that the impeller doesn't have to be so close to the housing of the pump. So the gap in here, again, between the impeller and the housing itself can be bigger. And so it's a little bit more forgiving for things that might get sucked in through the pump. Looking over time, the HeartMate 2 was the first of these continuous flow pumps, and it gave way to the HeartMate 3 because in the HeartMate 3 trials, it was compared against the HeartMate 2, and the HeartMate 3 was just clearly a superior pump for a lot of reasons, but thrombosis was one of the biggest reasons that the rate of thrombosis for the HeartMate 3 was virtually nil. And then the HVAD was a reasonable pump, but had its issues. It had higher neurologic adverse event rates than the HeartMate 3. And then there were some controller issues that came up. And the maker of the pump at the time, Medtronic, decided it just wasn't worth the hassle financially. And they pulled it from the market a number of years ago. So now we're left with a HeartMate 3, which is not so bad, that it's a great pump and it has really good adverse event profiles. It'd be nice if we have more devices to play with, although some are coming along the track. It's just the HeartMate 3 now that we're implanting. So from the pump, it's powered by a driveline that's tunneled subcutaneously, usually through the right upper quadrant, although that, depending on sort of anatomy and some other factors, it might not necessarily go out there. And that's attached to a controller, which is basically the brains of the operation. It can show the user and the physician some basic pump parameters. It can show you pump alarms. And then that is subsequently connected to a couple of batteries, which powers everything. And so I think whether you're looking at the HeartMate 3 or the HVAD or the HeartMate 2, all those pumps basically follow the same configuration.
Just to provide a little additional color to that, I think, the generational changes in these pumps has been spectacular. And I think it's important to think about. I know you said, let's talk about the new generation of pumps, but it's important to think about not too long ago, as in 2001, 2002, which I guess maybe some of the years some of your listeners have been born, but we're aging ourselves here. These pumps, the only way we could drive them was by putting air in and out of the patient's body. I've implanted pumps, the HeartMate XVE, that was a technological advantage because it went from being pneumatically driven to a electronically driven piston that was going back and forth. I've also put in pneumatic pumps, the Thoratec PVADs, that, believe it or not, we were sending people home on. And these were pumps that were huge. They'd sit outside of your body. We were called paracorporeal pumps as opposed to intracorporeal pumps. And they would be driven by gas lines. And they had these huge washing machine size controllers that people would go home with, and they'd be making all this noise as the pump was pumping air in and out of the patient's body to generate a pulse. And so, we've come a long way. There's a long way to go, but we've come a long way. And even when you look at the generational differences with the current pumps, the implantable pumps have gotten so much better. Implanting a HeartMate 3 is so much easier than implanting a HeartMate 2. Explanting a HeartMate 3 when it comes time to transplant them is so much easier and safer than doing the same thing for a HeartMate 2. And so there's the physiologic improvements that have been made, but there's also a lot of technologic and usability improvements that have happened too.
Yeah, you guys have never had the pleasure of going to clinic and sending an XVE filter for titanium analysis to see if the pump was breaking down.
Yeah.
I was just sitting here thinking about how, to me, I think that there's such a generational shift in how people who are training now think about LVAD, because we've really only seen the uncomplicated ones that, everybody gets a driveline infection, but very few people are getting strokes. Very few people are getting GI bleeds. I think that it's a shift, and I don't think we're as afraid as many people are. I don't have the deeply seated fear. And we're going to get into this, but just, I guess, to ask a question, as you're talking about sending somebody home with a washing machine size controller, I feel like, and there's been such a shift in the way that we think about this. It's not just a bridge to transplant anymore. It's something that gives people a real quality of life. But when you were implanting those devices, those were really thought of as bridge to transplant. Is that correct?
Oh, yeah. I mean, they were bridge to transplant. Unfortunately, they were pretty wobbly bridges. A lot of those patients fell off those bridges. I mean, and there's nothing more devastating than taking somebody who was, approaching death, and you would put a PVAD in them to try to support them to transplant. And then you're living in the world of the old allocation scheme, and they're status 1, but so are half of the people on your list. And it's a race against the clock of when they're going to clot off their chamber and throw a clot to their brain and have a stroke and no longer be transplantable. And so, yeah, you're very correct. The anxiety and fear that exists around mechanical support today is completely different and a very, lesser level than it did even 10 years ago.
That being said, when I came out of fellowship and I would see these sort of big pumps that we send people home, I was the attitude at the time was like, whoa, you can send somebody home with a heart pump, right? So it's, I guess it's the matter of just sort of the perspective. And it's easy to kind of look at the HeartMate 3 now and look back at that technology and be like, oh my gosh, that's so crazy. But at the time, it was like a real breakthrough. Like someone could actually go home with these things because they couldn't before.
Yeah, I mean, it was cutting edge, absolutely, right? Yeah. In the process, it was so cool, right? It's kind of like when you're a kid and you watch some movie that you think is the coolest thing ever, and then you watch it again as an adult, and you're like, wow, that movie's so lame. I can't believe I loved it so much as a kid, right? The same thing with the LVAD technology.
That's amazing. I think, Dr. Teuteberg, you did a great job going through, giving us a great overview of LVADs. And you touched a little bit too on the difference, between the pumps, and now we have centrifugal flow pumps, whereas before we had these axial flow pumps. And Dr. Daneshmand, I just wondered if you could touch on it, maybe give us a little bit of a surgical perspective too, on more specifically the benefits between axial flow versus centrifugal flow. And Dr. Teuteberg, you mentioned a little bit too, the data behind that, but I'd love to hear your thoughts on that. And then also just what are you excited about that's coming out in the pipeline? It was great to hear this historical perspective on the pumps, but now looking forward, what are you most excited about that's in the pipeline now for these LVADs?
Yeah. I mean, I think the difference between centrifugal flow and axial flow, in the way that it is implemented today is very much a technical difference around how the pump is managed. And it makes a difference because the hemocompatibility of the pump seems to be better with the centrifugal flow pumps, not necessarily related to the fact that there's centrifugal flow, but rather related to the fact that they can be magnetically levitated. The available technology for centrifugal flow has to have physical contact. And the HeartMate 2 had these ruby bearings that were at either end of the stator that would keep the rotor centered in the stator so it didn't bang against the walls of the stator. So when the rotor was spinning, it was generating heat. And because there's mechanical friction. Now that heat is almost completely obliterated in the magnetically levitated systems. Now, the magnetically levitated systems generate heat too. Their heat comes from the electrical components and generating the magnetic fields and all that stuff. But it's not as focused as it was with the axial systems, right? The heat that was being generated before was right at a pinpoint where this hard ruby bearing, and the reason they used rubies is because it's on the Mohs hardness scale, it's 9 out of 10. The only thing harder than a ruby is a diamond. And so when you have a metal on ruby connection, that's actually a very stable connection and is unlikely to have significant wear. But just because it doesn't have significant wear doesn't mean that you don't generate friction. I'm going to go on a sidetrack here. One of my hobbies is watchmaking. And, this bearing is borrowed from watchmaking. So when they created these VADs, so if you look at a mechanical watch, all of the gears sit in ruby bushings and ruby bearings to keep them from wearing over time. Now that interaction needs to be lubricated in a watch. That's done with oil. And, you have to routinely maintain that, somewhere every 5 or 10 years, you got to clean it, take it apart, clean it and re-lubricate it. In the human, it was done with blood. And so there was a film of plasma and blood, no red cells, but just plasma that would coat these bearings. And the thought was that it would wash through, but there was such a focal point of heat generation that proteins started to denature and they would precipitate out of solution. And when they did that, then the friction increased, the amount heat generation increased, and then your hemocompatibility profile went away. So the issue wasn't so much, in my opinion, axial flow versus centrifugal flow, but rather levitated rotors versus physical contacting rotors. So when you look at the group of levitated rotors, there's the hydrodynamic bearing versus the magnetically levitated rotors. Now, the hydrodynamic bearing is like the frisbee, right? So as long as it's spinning and moving, it's floating. When it's not spinning and moving, it won't float. And if you get a big wind gust, then it may move its directions, right? And that was what was going on with the HVAD system, is that you had to run it at least at 1800 RPM. You had to prime it correctly. It had to be wet. You couldn't run it dry. If you did, it would bang against the sides and damage things. That's not what happens with the magnetically levitated rotors. And I think that's really the crux there, is a stable rotor, large gaps, minimal heat generation. Whatever heat is being generated by the HeartMate 3, it is now being synced out into a larger profile. The entire physical size of the HeartMate 3 is sinking the heat out to the body and the blood flow, as opposed to a lot of that heat just being at a pinpoint and a bearing interaction.
Yeah, I mean, and I think that, could you say, well, if you had a HeartMate 2 design that sort of spun it magnetically, but also levitated it magnetically, would that be just as good as the HeartMate 3? Potentially, I guess. And we just don't have that pump. It just sort of wasn't designed that way. The other kind of subtle differences are that the axial flow pumps generally spun faster than the centrifugal flow pumps. And so from a rheologic perspective, in terms of sort of blood, the fragility of blood, there may be a little bit more hemolysis with axial flow pumps. The response to suction is a little bit different. I won't get into the gory details of HQ curves, but their HQ curves look a little bit different. So axial flow pumps tend to, when they get suction events, they tend to suction even harder. Whereas centrifugal flow pumps don't tend to do that as much. So there are subtle differences, but again, I think if you sort of otherwise kind of equalize all of the other design things that we've talked about and make an axial flow pump like the HeartMate 3, there's no reason, I guess, it wouldn't be as good. But practically speaking, I don't think there's a whole lot of difference once you get to that point.
I think, I just want to have amnesty here. Jeff mentioned HQ curves, so I'm good. I don't want
to. I can hear your listeners turning off the podcast right now.
And I think it's interesting. A lot of research that's going on around pump design is focused on the HQ curve. I think it's an important component of it, right? And the big move in a lot of new pumps is flatter and flatter HQ curves. Okay, and so what's an HQ curve? Essentially, an HQ curve, just briefly, is the difference in flow based on the difference in the pressure gradient between the inflow and outflow of the pump at a given RPM. Okay. And so the flatter it is, the more that pump is going to be responsive to pressure differences. And the steeper it is, the less it's going to be responsive to pressure. Why that matters is that when you have a pretty steep HQ curve, like you had with the HeartMate 2, as Jeff said, the pump didn't care as much about your preload and afterload situations. And so efficiency of the pump was based on the speed at which the pump was going. And the algorithm, there was no algorithm in the pump to kind of accommodate that. It wasn't a smart pump. You just set it and something happened. It's different than the previous generations. Believe it or not, I think that the pump control technology of the PVAD and the XVE was better than the HeartMate 2 and everything we had else, because those pumps had fill sensors. And so as soon as the pump became full, it would eject out, and you could control how hard it ejected. You could control the stroke volume. You can control all those things. And so they were very responsive to physiologic changes in the patient. Whereas the HeartMate 2 was not. If you set it to 9,000 RPM and the patient got a little dehydrated, their ventricle would get sucked down, and it was, now the RV's ballooning out or something. Or probably it's a combination of things, and you've created such high negative pressure in micro areas within the LV chamber and micro areas within the pump that you're lysing red blood cells and you're bringing proteins out of solution. And then that's causing debris to form on the pump, and, strokes and things like that happen. But anyway, again, I want amnesty. I didn't say H.
Yeah, I mean, it was the kind of funny old days of the PVADs when your patients would get volume overloaded, their pump rates would go up. When they got dehydrated, their pump rates would go slow, or if they got RV failure, their pump rates would slow down. So it was just like a totally different group of things that we paid attention to that we don't pay attention to anymore.
Amazing. Thank you, guys. I guess just to follow up a little bit. So, and you touched on it, things that are kind of in the pipeline of, I mean, ideally we'd have a really small pump that never clotted and caused no stroke. And there's no drive line because
It's called a heart transplant.
Yeah.
Sorry.
And, and, there are clinical trials going on right now of pumps that are not the HeartMate 3, which many of our listeners that's the only thing that they've seen. Maybe they have an old LVAD that's waiting for a transplant. So I guess I'm just curious briefly what you guys are excited about in the next, 3 to 5 years.
So the one pump that's in trial in the US is the LVAD, which is a centrifugal flow pump. Brio Heart is the company, and the trial is called Innovate. And it's randomized against the HeartMate 3, I think 2-1. And they've implanted a number of pumps. I can't remember exactly where they are. I'm running their adverse event committee, so we're sort of starting to see some of the adverse events come through. But, it's largely the same as the HeartMate 3. It has a smaller driveline and a more flexible driveline than the HeartMate 3 does. I think that's kind of one of the downsides of the HeartMate 3. The only pump we have available clinically, so it is what it is. But a pump like the HVAD had a smaller driveline. It was a little bit more flexible and maybe didn't have as much pressure on the skin as the HeartMate 3 does. And then there's some TAHs that are coming into trial as well. There's other pumps that are looking at sort of kind of going back to the beginning again, having a more pulsatile delivery of flow. And there's potential advantages and disadvantages to that in terms of things like recovery. But those pumps are still not in trial yet. So there's a lot of interesting things coming down the pike, but nothing quite ready for humans. And then the other big sort of thing that a couple of pumps have done and a handful of patients is having the power internally so that you can sort of detach yourself and have some kind of drive. You don't have a drive line and you have a little bit of time that you can kind of go without having something attached to you in terms of batteries powering the pump. That's still kind of lagging behind. The battery technology is one of the big things that it hasn't sort of caught up just yet. I mean, I think everybody always says, geez, I can recharge my toothbrush without it touching anything or being plugged into anything or directly plugged into anything. Why can't I do it with my VAD? And it's just not quite there yet, although it's getting better. And the other thing that's sort of keeping that from being actualized, I think, is that the pumps themselves are pretty inefficient, meaning that the amount of energy they require, very little of that actually is translated in actually spinning the pump. And that's not a big deal when you're hooked up to power 24 hours a day, 7 days a week, right? Because it doesn't matter how inefficient you are, you're always getting your power. But when you're asking it to sort of draw power from a battery, then all of a sudden efficiency matters. And so translating something like a HeartMate 3 into something that has internal batteries, the battery thing is important, but the pump isn't maybe as efficient as it could be. So I think that's also something that's slowly being designed into pumps as we sort of move forward.
I think, and that's where some of these newer technologies that Jeff kind of touched upon may actually be the way to when you want to go to a totally implantable system. Probably, spending a lot of energy floating a rotor in the middle of a pump is not going to be the best way you do it. So I think it's good that we're exploring other technologies. There's a pump out there that has a wave membrane that, called CoreWave, I think. Yeah. There's a pump called the TorVAD that's using 2 different magnets that kind of move back and forth. I think some of the companies are sitting there and looking at it and saying, oh, well, we need to generate a pulse. We probably don't need to generate a pulse. I think, Bud Frazier, who is one of the titans in MCS and cardiac surgery, famously said at the ISHLT, I think we have proven that nobody needs a pulse to live, or something like that, right? I don't know if you were there, Jeff, if you remember that talk. In pursuit of the pulse, some other technologies may come forward for making the blood move around that are going to be more compatible with totally implantable systems. And, I always say, Jeff mentioned what you've described as a heart transplant. And yeah, heart transplant is great. But heart transplant is never going to make an epidemiologic impact on heart failure. The only way we're going to make an epidemiologic impact, short of somehow finding some way to make everyone recover their heart function, or, some kind of magic trick with xenotransplantation, which I think is just as far-fetched as what I'm just about to say, is to find a, totally implantable solution. Imagine a world where you get an LVAD and that LVAD is just like an ICD, and every 5 years you go and you get a battery change out, and otherwise you're good, right? Like everybody would sign up for that, right? So when you talk to the companies and you tell them that, they understand it. But yeah, battery technology is a problem. Keeping the electrical connections to the battery inside the body without them getting corroded is a problem. There's all these things that I never even thought about until I really kind of push the engineers and say, well, why can't you do this? And they start describing all these human device interface things that happen as your current goes up. You create a capacitor inside the body that can cause rusting of all the contacts just because of the amount of energy that's being stored and how quickly and for how long it's being transferred. The heat generation of this thing is a big deal. That being said, I do think the right ventricle is also the kind of stepchild of the heart failure family. This process started in the 1960s looking for a total artificial heart, and it was a really hard problem to solve. And then LVADs kind of took off and we ran with it, but we've orphaned a large portion of the heart failure population who can't get a heart transplant, doesn't have a good enough RV for an LVAD, and they're just kind of languishing and dying. So these total artificial heart technologies that are coming out excite me. I am sad that the CARMAT device trial is dead in the water in the United States. They ran out of funding. So we're down to one total artificial heart device that's currently in testing, and that's Vivacor. And it's a beautiful device. It's genius, actually, when you think about how it's designed. It has an impeller that is magnetically levitated that automatically balances left and right flow based on different preload conditions. So I think it's really genius design, and, let's see what the studies show, though.
Oh, that's amazing. Thank you, guys. I think what I'm hearing is we're pretty far away from the perfect LVAD, but a lot of exciting stuff yet to come. We can move on to our next case. I thought for our next case, we were going to join our heart failure team, moving from clinic to rounding up in the cardiac ICU, where we're asked to see a 73-year-old male. He initially presented to an outside hospital with shortness of breath, was found to be volume overloaded. He was also noted to be cold on exam, tachycardic, and hypotensive with a systolic blood pressure of 85 millimeters of mercury. He had an echocardiogram done that showed a newly reduced left ventricular ejection fraction of 10%. His left ventricular end diastolic diameter was 7.2 centimeters, and he had moderate to severely reduced RV systolic function and moderate mitral regurgitation. He had a left heart cath done that showed severe stenosis in the distal right coronary, but otherwise non-obstructive disease. And he was transferred to our facility in our CICU for consideration for advanced therapies. When he arrived to our CICU, a Swan-Ganz catheter was placed, and this showed the following hemodynamics: a mean right atrial pressure of 15 millimeters of mercury, a pulmonary artery systolic pressure of 53 with a pulmonary artery diastolic pressure of 24, and a mean PA pressure of 37 millimeters of mercury. His pulmonary capillary wedge pressure was 30. His FIC cardiac index was 1.4 liters per minute per meter squared, and his PAPI calculated at 1.9. His creatinine was 1.3 from a baseline of 1.1 about 6 months prior, with an estimated GFR of 40. And he started initially on a dobutamine infusion at 5 mics per kg per minute, along with a continuous diuretic infusion of furosemide 20 milligrams an hour. His BMI is 22 before diuresis, and he's 6 foot 2 inches tall.
Thank you, Josh. So I guess to summarize our case, we have a 73-year-old male. He's presenting in heart failure, cardiogenic shock. He has acute heart failure secondary to a primarily non-ischemic cardiomyopathy. Intermax profile 3, which is stable on a continuous inotrope, who is being evaluated for advanced heart failure therapies, most likely DT-VAD based on age. So, Dr. Teuteberg, when you hear about this patient, what are your thoughts about his advanced therapies candidacy? And what does or does not make him a great VAD candidate? And maybe we can touch just briefly on why he's not an ideal transplant candidate. We've also kind of used the word destination therapy or bridge a few times during this episode, so maybe you can discuss the difference between what we call DT and bridge to transplant.
Yeah, so maybe kind of going backwards a little bit with your questions. Everything was bridge to transplant when VADs first started, because it was basically that was the whole point. People are getting sicker and they can't wait and their heart's not becoming available. Can we put them on a pump to get them to transplant? And then in the days of sort of the pulsatile pumps, the XVE era, when people were doing better by current standards, not great, but better than they had been, people started asking, well, could we keep people going on these pumps for longer periods of time? And maybe they could serve as an alternative to transplantation in people who have contraindications to transplant, which is usually age and comorbidities. And that was the rematch trial. The outcomes of the rematch trial for the patients who got the pump don't look great compared to current destination therapy trials, but it was sort of a new concept. And so destination therapy, people have tried to rename it for years and years. And I don't even know how it got the name destination therapy. It's a terrible name. But people have been trying to call it like lifetime therapy and a bunch of other things. But DT is just sort of stuck. But that's basically getting the pump as in lieu of transplantation because you have contraindications to transplant. And then there's like bridge to recovery. That's not really an officially recognized indication. This is for people who might have a recoverable myopathy. And so you put the pump in and hope that the person's heart might get better. And then you could eventually remove the pump. But basically it's bridge to transplant and DT. So what would make this guy not a great transplant candidate? I think his age and frail, it maybe sounds like he's a little bit frail, maybe a little bit malnourished. Those are probably the kind of things that kind of jump to my mind. Could someone like that be transplanted? Sure. Have we transplanted people in their early 70s? Yeah, but they're usually pretty robust otherwise and don't have a lot of other medical problems. So it's I always sort of say it's not the age, it's the mileage. There's some 73-year-olds who look great and don't have a lot of mileage on them. And there's some 43-year-olds who don't look so great and they're not great candidates for anything. So it sounds like he's pretty sick. I guess it's reasonable to hold out hope. My friends at Utah would yell at me if I didn't at least mention recovery, that, the person comes in, if this is their first exacerbation, right? So never really been treated, never really got GDMT, doesn't have coronary disease. Maybe you could turn this guy around. Sounds unlikely. He has a big ventricle, really low resting index despite being on inotropes. So it doesn't look great for this guy. Things that we always worry about, we kind of already mentioned a little bit, was what's going on with the right ventricle, at the Achilles heel of left ventricular support. It sounds like he has some RV dysfunction by echo, and never judge a book or an echo by its cover or whatever however you want to sort of say that. I don't care what the right ventricle looks like. It's more what the hemodynamics show. And despite having like an RA in the mid-teens, he can generate pulmonary hypertension. So in the mid-50s PA systolic. So that's in and of itself a reasonable sign. The PAPI is sort of one thing that I think people talk a lot about, the pulmonary artery pulsatility index, so basically the pulse pressure in the PA divided by the right atrial pressure. And sort of roughly around 2 is a cutoff. Below that is bad. Above that is maybe not so bad. The reality is there's been a lot of things looked at to predict RV failure post LVAD, and none of them really work that well. The reason there's 1,000 things people looked at is because none of them work, right? So, and it kind of depends on the situation too, right? So there's a PAPI of 2 when you sort of roll in and you're not on any hemodynamic support. And there's a PAPI of 2 when you're on 3 inotropes and, a balloon pump. And does that same PAPI mean the same thing in both those patients? From the standpoint of the studies, yes, but practically speaking, no, right? So, I think that it's really hard to tell. And I think some of it is a collection of all the different parameters people look at, RV stroke work index and RA to LA ratio, and a little bit of this and a little bit of that on imaging and tissue Doppler and what have you. But it's all kind of a witch's brew of things. And then everybody stares at each other during the meeting. And if the person's really young and otherwise a good candidate, you say, yeah, let's move forward. And if the person has a lot of contraindications, then you say, oh no, this person's RV is way too sick and we're not going to support them. So it's a little bit of a hocus pocus, but I think there is some science there, but it's still really hard to predict. Because ultimately, as Manny can tell you, you can take somebody with a stone cold normal right ventricle by all the measures that we look at, and they go to the OR and they bleed and they bleed and they bleed, and you give them lots of blood products and you trash their lungs, and all of a sudden the RV doesn't look great. At the same time, you can take someone who has RV numbers that look terrible and everything that we'd say, oh my gosh, this person's going to do terribly. But maybe they're a primary chest and you get them through the OR and they do okay. And, the RV does just fine. So there's a lot that can happen in the OR too, that I think really complicate the interpretation of some of these RV hemodynamics in addition to the limitations of the measurements themselves. So, all in all, the guy seems like a not bad candidate for transplant. It'd be nice if he was a little bit more robust, but otherwise I think he's someone that I think is a pretty, I don't know, run of the mill DT patient these days, I think that we see.
I think to Jeff's few points, the biggest thing I want to emphasize is we don't know about the RV, right? I have never been able to predict if an RV is going to work or not. And I find it interesting that a lot of people think they can because, I've been doing this for a long time and I have never been able to predict. I do think we can probably limp through a lot more RVs than we think we can in the meeting, and some element of temporary RV support, while it does put you on a different survival curve after your VAD, that survival curve is still better than not getting a VAD. If your options are that or hospice, you're going to do better with the VAD and some temporary RV support on average. And again, depending on your definition of better. For some people, hospice may be the better option. I agree with Jeff. The reason there's so much studied is because this is a hard question to answer, and it's impossible to put it into a study because there are moves in the operating room that different surgeons will do different ways that will impact how that RV is going to recover. And one of the things that I think is really important, and I've never been able to prove it, except for the fact that I feel like I have, that I have a lot less mechanical support of my right ventricle in super sick patients than other people, is opening the left pleural space widely and putting the pump outside of the pericardium. I tell all of our residents when we're doing the LVAD that the biggest lie that was put together in LVAD therapy was that the HeartMate 3 or the HVAD is an intrapericardial pump. It should not be an intrapericardial pump. It's an intrathoracic pump. And so, I open the left pleural space widely. I put the pump into the left chest. And the reason I do that is because if I don't, then the LV apex is moved medially and the right ventricle accordions a little bit. Now, the strong right ventricle in most people does fine with that. But the sick right ventricle that's just essentially a passive Fontan conduit, doesn't do as well with that. And when you return that LV apex, it really maintains its geometry and is able to do better. But that's one of the many different technical things that could be different from surgeon to surgeon and from case to case. Let's not also forget how important our anesthesia colleagues are and our perfusion colleagues are. If during the case, the patient's being underperfused because the perfusionist thinks, well, we have a SVO2 of 80 and that's good enough, even though we're flowing a cardiac index of 2.1 and the patient's kind of having a little bit of accumulation of lactate and all that stuff, maybe that patient doesn't tolerate coming off pump and as well as the patient who's been running a cardiac index of 2.5 or 3 and has an SVO2 of 95 the whole case. Who knows? We don't know the answers to any of these. These are all the different variables. When you're coming off pump, the anesthesiologist, maybe they're maintaining a map of 65, maybe they're maintaining a map of 95. Does that make a difference? And so much of whether or not you're going to have RV failure has to do with the couple of hours in the operating room, right? If you get out of that OR and your RV is doing okay and your RV is not dilated and your CVP is not 25, you're probably going to make it through that hospitalization without an RVAD and the patient's probably going to do okay. But, the first time you let that RV kind of dilate out and those sarcomeres, separate from each other, the actin and the myosin are no longer overlapping, well, that RV is going to be sick for 3 weeks after that. And that, again, puts the patient on a different trajectory. And so it's an impossible question to answer, I think, whether or not that RV is going to go, because so much of it is unpredictable and uncontrolled. So I don't know why I went down this pathway, but
well, everybody heard Manny say it. So it's the surgeon's fault that we have RV failure after LVADs. So the heart cardiologists can totally absolve themselves.
It is on us. It is on how we manage the patient in the OR. It's how our teams manage, how the anesthesiologists manage. On average, 95% of the time, now, are there cases that we're never, ever going to get out with an RVAD? Yes. And are there cases that are always going to come out no matter what you do fine with their RV? Yes, sure there are. But when you're in that, the Ross and Rachel situation, will they, won't they? will the RV be okay? So much of it is dependent on how that patient is managed in the operating.
And, even things like when I first read the case, I was like, oh, it's a proximal RCA occlusion, but it was more of a sort of a distal. So I don't think you need to do anything with that. So, what do you do with someone who may have a little bit of ischemia or the graft of the RCA doesn't look so good? Do you graft it during the time of the implant? What do you do with a tricuspid valve? How much do you fix it? Do you not? How much? When do you do, those sorts of questions are still floating around out there. And I think people don't really know. And the other sort of big part of the RV failure conundrum and why we can't get great answers is that the endpoints aren't great. So, and I've been looking at sort of RV failure and Intermax for a long time. I kind of run the RV task force, sub task force and Intermax. And, for a long time, it was just whether or not you ended up with an RVAD. For some people, it's a good thing, right? You get an RVAD and then that allows you to sort of bridge the RV to some sort of recovery and get better. So that isn't even the greatest definition. And then we started looking at long-term RV failure, and there's, we published a little bit on that, and it's probably more common than we thought was. Generally speaking, once you get RV failure, it tends to come back, although some people don't necessarily. But even then, I don't think the way we define sort of long-term RV failure is perfect. So coming out relatively soon, we just totally redid the definition of RV failure and Intermax. So hopefully we'll start to maybe learn a little bit more, not only about sort of acute RV failure. I'm not sure there's a ton more to learn about that, but I think more sort of what is the long-term implications? Because if it impacts exercise tolerance, if it impacts quality of life, if it impacts those things, then particularly for someone who's getting it as destination therapy, those things matter. And I don't think we have a really great way of predicting those things and then sort of adequately communicating with the patient about sort of what that means over the long haul. So lots to learn.
Thank you both. I think that two things to highlight. I didn't understand the importance of what happened in the OR until I got to fellowship, and all of a sudden the patient comes out and something's happening and you realize you really have to understand what the OR was like and what was going on there to be able to care for that patient appropriately if something is urgently happening. And then, we love talking about the RV at CardioNerds. So it is great. Mark Belkin, I'll have a lot of things to say, I'm sure, too. But just quickly, Dr. Daneshmand, can you just, for our listeners thinking about surgical limitations, this is a tall guy, he's 6'2", his BMI, when you diurese him, say it's a little low at 20, he has a big ventricle. Are there kind of no-go surgical considerations for you that you feel like LVAD is not an option? Maybe like a smaller woman with HCM obviously wouldn't qualify, but just, I guess, kind of for our listeners, what do you think about?
I'm on the aggressive end of the spectrum of surgeons, especially when it comes to mechanical circulatory support. And, I think you mentioned one of our biggest red lines, and that's going to be the small ventricle hypertrophied myocardium patient. And I specifically said it like that because especially with the HeartMate 3 now, the inflow cannula is so small that probably if you have a small ventricle, thin myocardium patient where you are not getting a complete chamber collapse during systole and things like that, you probably can get away with a HeartMate 3 in those patients. And we, in fact, have gotten away with HeartMate 3s in those patients. Are we having, running those pumps slower and having lower flow? Yes. Is it more partial support than full support? Yes. But we're still able to get away with it in select patients that meet that phenotype. Where we've always struggled, and then again, a little bit of history. There's a period of time where when we were in the HeartMate 2 days, if you had a patient with hypertrophic cardiomyopathy, so small chamber, thick muscle, we were going in there and coring out a whole bunch of muscle, trying to see if we can create a chamber to put these pumps in and all that stuff. And it just didn't work. Now, admittedly, I've not done that with a HeartMate 3. And, I've not done it with one of the trial pumps that have also kind of slowed down. I think that trial is the AvaHeart. AvaHeart was a different technology pump, and the rest of the pump was kind of really backwards and old. But where they really did a nice job is their inflow cannula never went inside the ventricle. You'd create a hole in the apex, and then you connect a device to the apex that captured the hole. So the left ventricle itself became your inflow cannula. And so in that scenario, for somebody with a small chamber, that may be something that works. But regardless, anatomic considerations, people talk about chest size, people talk about chest diameter. Our pumps have gotten so small that for the most part, in adults, you can put it in anybody. This guy having a BMI of 18, 19, 20 post-diuresis would not give me pause. And actually, I think that person would do really well with LVAD therapy, because I bet a significant component of their skinniness is due to cardiac cachexia. And once you get them feeling a little bit better, we'll put some meat on those bones and they would do better. A lot of the nervousness that came from smaller patients had to do with the XVE, where you had to put a dinner plate sized pump in the person's abdomen, or even the HeartMate 2, where we had trouble in people who had body surface areas of less than 1.5 to fit the pump, and we couldn't put it in anybody with a body surface area of less than 1.2, right? We really struggled with that. HeartMate 3, it's not been an issue. And so there are very few things. Now, one scenario anatomically that would give me pause and we'd have to think about is the scenario of a calcified LV apex, right? That would result in both an increased risk of stroke and increased risk of bleeding from that LV apical connection. And so I would worry about that, but body habitus, I wouldn't worry so much about.
But I'm just curious, like for your patients who are really cachectic and skinny and don't have a lot of sort of abdominal fat, does that sort of change how you think about or how you tunnel their driveline?
Yeah. So, I think it's not a common problem here in Georgia, living in the,
Yeah, it wasn't either.
that may be more of a Northern California issue. I think where actually it really changes me is in the super obese, where I actually think about it is they're at a higher risk for driveline infection. I wind up, tunneling it a little bit shorter to a less flabby area of the abdomen, so that to try to limit the amount of motion that happens. I've been thinking about, I have not done yet, but I've been thinking about considering tunneling it out onto the thoracic cavity in some of these patients, especially in the super obese, because, the amount of skin motion that happens over a rib is significantly less than the amount of skin motion that happens in your abdomen. And I think, as we all know, that one of the biggest causes of driveline infection is trauma and motion at that skin, driveline interface. And so I wonder if we could minimize that by selecting a better place, a more stable place to bring out the driveline. But I have not done that yet. The cachectic person or the small person, where we used to have a big problem with the HeartMate 2, because it had a very long and hard driveline, more than even the HeartMate 3, but also it had a long piece of velour that was hard to get in there. And I don't know if you remember, Jeff, there was a period of time where we were kind of wrapping the driveline inside the patients, and especially in the thin patients and stuff. And then they were kind of kinking and breaking, and you were having driveline failures inside the body from that. Haven't had as big of an issue, and I don't really do anything different in the cachectic patient for HeartMate 3.
Yeah, I mean, because the one place where the bad old days might be the good old days is the Jarvik, right? Because you could tunnel your driveline up to sort of behind your ear, and then screw the pedicle into your skull behind your ear, which is where a lot of people with vestibular implants got their implant, and it's much less likely to get infected, right? So, it's kind of crazy. And you think about it, I'm sure you guys have never seen one of those, but we had some patients with Jarvik back in the day, and those things didn't get infected.
They never got infected. Yeah, they never got infected. And, I am disappointed, and I wonder if there's IP around that connector that's been buried. And so I'm disappointed that none of the new pumps have utilized that approach, because it really was a good approach. And if there is IP, shame on whoever's buried that IP, because it's hurting a lot of people. They should license it to every single pump manufacturer.
That was really great and super helpful and insightful to know about, all the physical considerations we think of outside of the cardiac pathology going on, considering taking patients for a VAD. So sort of along those lines, going back to our case, our patient actually demonstrated an improvement in his RV function following impella pump placement. The use of these devices is common, sometimes as a bridge to decision, with suggestion that they have a role in preoperative rehabilitation or prehab before undergoing durable LVAD or heart transplant. We know, of course, that no device is without its own inherent risk. So, could you just briefly discuss the role of devices like Impella 5.5 for prehabilitation prior to durable LVAD? And do you have a specific threshold you like to see patients reach in terms of like a physical ability before you take them to the OR?
Maybe I can start. I guess I'm of two minds with the sort of optimization. I think there may be some use for taking if you think the person's under supported by say inotropes, and this guy's, let's just say he's on, I forget how much dobutamine he was on. Let's just say it was 5, and his index is still not great, and his filling pressures are still high, and his end organ function isn't great, and maybe his RV doesn't look awesome. Is there potentially a role for using something like a 5.5 to really increase the flow, really decongest him, decongest his lungs, decongest his liver, decongest his kidneys, improve perfusion, and make him look a little bit better beforehand, and then maybe even get a better sense of like what's going to happen with the RV when you start to kind of suck a lot of blood continuously out of the left ventricle? I think the answer is that's probably yes. The thing I worry about is sometimes we get kind of caught in this, like, well, we're going to quote unquote optimize this patient before their surgery. And there's really no endpoint, right? So no patient, almost never do you say like, we're going to do that. And we want this, this, and this to happen. And this, and this actually do happen. You get like a half of this and a quarter of that and 2/3 of the other thing. And then everyone's like, well, let's give him one more day and see what it looks like tomorrow. Well, let's give him one more day and look. And then all of a sudden they're on ECMO or they look terrible or they're getting implanted emergently. And so I guess I'm careful about that. I think under sort of really reasonably circumscribed criteria, you can do those sorts of things. I just wouldn't let it drag on if they're not really improving much. People are saying, well, my patient is really debilitated. If I put a 5.5 in through axillary, and then we can walk him around and work on his nutrition and get him stronger. I mean, that sounds really good, but practically speaking, I'm not sure I've really ever seen that work. Like, can you get people out of bed? Yes. Are you more likely to run into a problem with the 5.5, which is a great pump? This is not a negative comment on the 5.5, but in the sort of weeks it takes to really make some change in that person. I mean, they're malnourished, their muscles aren't super robust. And I just said that their nutrition isn't great either. And so are you going to really make a huge difference? Probably not. Are you going to just delay things, or are you hoping that they get a complication so you don't have to implant this high-risk person, which I think is what happens a lot. Like, well, let's just try and rehab them and they get a complication. Then it's like, oh, too bad we can't implant that person. So I'm very cautious about prehabbing. I don't know that there's a giant role for it. And I think you need to be kind of cautious about what sorts of criteria is set for patients to meet, so you don't prolong the wait for surgery and make them get sicker before you go to the operating room.
Yeah, I agree with Jeff, and the caveat is at Emory, we are probably the largest implanter of the Impella 5.5, as well as a HeartMate 3 in the world, right? No one's doing more Impella 5.5s than us, and we use a lot of them. But I think you have to understand that an Impella 5.5 is not a HeartMate 3. When you put an Impella 5.5 in somebody, you are unloading their ventricle some, you are giving them some AI, you are putting something in there that may or may not have as hemocompatible profile as the HeartMate 3. The pump itself currently is FDA approved for 2 weeks of support, not 2 months of support. Do we have patients at Emory who've had an Impella 5.5 in and have done fine at 6 months? Yes, we do. Can you get people on long-term support of Impella 5.5? Absolutely, you can. But that cannot be plan A. It should not be plan A. And to Jeff's point, you're not going to take that patient and, convert them from a malnourished little skinny cachectic person to, Jack LaLanne, which is also an old reference, I'm sure. It's like,
I get it. That's okay.
Everyone else can Google who Jack LaLanne was, or I guess now Chat GPT who Jack LaLanne was. But, you're not going to do that in the time frame of support of an Impella 5.5. So what do we do at Emory? We have a lot of people who show up at our doorstep significantly decompensated. And so if you're hanging out on, 0.5 of milrinone and you have a wedge of 40, or if you're hanging out on 2 inotropes and you have an elevated wedge and you're not really diuresing well and your CVP is 25 and we still don't have LVAD approval from your insurance, we're going to put an Impella 5.5 in you and we're going to use the, 3, 4, 5, 6 days that it buys us to dot all the I's and cross all the T's and then put a LVAD in you. We're not going to sit on you for a month hoping that there's going to be an impact to any of your long-term parameters because it's just not going to happen.
That's super helpful. And that I think just again reiterates, and I appreciate the thoughtful approach to putting these pumps in people. And I think, like Shazli mentioned, they're not without risks. And I think it just takes a really thoughtful approach. So thank you guys. That's amazing. For our final case, actually, we'll head back down to our heart failure clinic. We have one last patient in clinic today. She's a 39-year-old female, and we're following her up after she had actually explant of her HeartMate 3. Briefly, in terms of her history, 2 years prior, she had presented to her hospital at her 34th week of pregnancy. At that time, reporting dyspnea, orthopnea. She had significant edema and was found to have a new diagnosis of peripartum cardiomyopathy. She was ultimately delivered on VA ECMO, and after failure to wean her inotropes after ECMO decannulation, she underwent a HeartMate 3 implantation. She did well postoperatively with significant improvement in her LVEF and was able to undergo a LVAD explant 6 months later.
Thanks, Josh. I love sneaking pregnancy into these, into these podcasts, whether or not it's supposed to be there. So I guess in summary, we have a young female in heart failure clinic this afternoon, and she had HeartMate 3 in the setting of a new diagnosis of peripartum cardiomyopathy and was luckily later able to undergo an explant. So to both of you, really, when I was in residency, I thought of destination LVADs as something we put in 70-plus-year-old patients, and we did heart transplants for young patients. And I'd love to discuss the role of LVAD therapy in the younger population. Is it something we should be considering in these patients to spare them early transplant? I know there's a lot of debate about this. There's all the Intermax data. Mary Jane Farr had an opinion about it. So I would just love to kind of hear your thoughts, just particularly as a provider that takes care of a lot of young women that have potentially recoverable but not always recoverable cardiomyopathies.
Yeah, I mean, I guess it's always good to think about it. It doesn't happen super often outside of select populations. I want to give sort of all the props in the world to to Stavros and all of his colleagues at Utah who've really kind of driven forward the science of recovery. I think there's a lot to learn there, right? And do we know for sure the best way to sort of manage pumps and GDMT to sort of maximize the chances of recovery? No, I think we're still kind of trying to figure that out. And I think we're still also trying to figure out who are the people that are just lost causes and who are the people that we should really try. Aside from women with short durations of heart failure with small ventricles, right? Those are the people that are, and when you sort of look at those populations, maybe 25% of them will recover. When you look at Intermax populations, 1% recover to the point where you can actually take the pump out. If that's your definition of recovery, right? And so a lot of what the Utah folks would argue is there's lesser degrees of recovery in terms of when you look at the echo 6 months later, there's more contractility, or when you turn the pump down and look at the echo, there's more contractility. So maybe they're not ready to have the pump out yet, but maybe that's sort of more subtle signs of recovery. And there's more things that we can do with those patients to get the pumps out, but we're not there just yet. So, I mean, that's kind of my sort of thoughts about recovery. So it's worth looking, particularly if people are in that sort of high incidence cohort that they might have recovery. So it's worth thinking about in the back of your mind. The replacement of transplant with MCS and sort of young people is kind of a totally different topic. Now that we have the HeartMate 3, and because we have really good long-term outcomes, it's worth saying okay, you're 25, you have end-stage heart failure. Should you get a VAD for 10 years and then get transplanted later so that maybe you only need one heart down the line, assuming it's going to last 15 to 20 years? I still don't think we're there just yet, to be honest with you, because there's still a mortality price you pay for getting the pump in. And there's still things that can happen while you're on the pump that could potentially keep you from being a transplant candidate. Strokes, sensitization from a GI bleed or something like that. Although admittedly, those things are much less common now than they used to be. And the question is 5 years enough, right? So if you're sick at 25 and you get a VAD for 5 years, are you really going to obviate the need for retransplant? Probably not, right? And if you're a 25-year-old, which was a lot longer ago for me than for you guys, but like you could say like, okay, for the next 5 years when you're probably, maybe you're going to get married, maybe you want to have a family, maybe you want to travel with your friends. Do you want to do that with a VAD or do you want to do that with a transplant? I say, well, what about for the long-term consequences? I mean, if you guys are anything like I was when I was 25, I wasn't thinking of the long-term consequences. Long-term was like the next week, let alone the next 15 or 20 years. And, I think it's tough to sort of sell that to a population where, you just kind of want to be like everybody else, right? You want to walk down the street, you want to go to your, frat party, or you want to go to hang out with your friends at the bar and not carry around all this stuff because no one can tell you how to transplant. And I'm not advocating drinking heavily after you've had a transplant, but just kind of going out and hanging out with your friends. I think there is something to be said about that. And, I think it's super intriguing. And I would like to think that maybe we'll get to that point someday. On the other age of the age spectrum, can you say, hey, maybe we shouldn't be transplanting 65 to 72-year-olds. Maybe they should just get VADs because the short-term outcomes look pretty good compared to mechanical circulatory support. And I don't know, maybe at the same time, we've almost doubled the number of transplants we're doing each year in the past 10 years. We're not as sort of transplant limited as we might have been in the past, but I think we still need to be sort of, it's still limited, right? You can't pull hearts off the shelves. So I think there's a lot of intriguing questions to be asked in that area, but I don't know that we're totally there just yet. I don't know, Manny, what do you think?
I mean, it's hard, right? Like I said before, it's so hard to make an epidemiologic impact with heart transplant. Now, can you say, okay, well, let's make the impact, let's reserve heart transplant for young people and VAD for old people, Would that make a difference? Potentially, but as Jeff pointed out, I mean, we're doing almost 5,000 heart transplants a year. We're definitely not at a point where we have, too many hearts and not enough recipients. But, the vast majority of those heart transplants are done in the older population. If you were to say, okay, starting today, nobody over the age of 60 gets a heart transplant, and all those hearts get allocated to people under the age of 60, I think we would very quickly be in a situation where we say, okay, well, we have too many hearts and we have to kind of, open things up again. The idea of, hey, why don't you take a VAD for 5 or 10 years, because you're young, sounds really sexy, right? Because you're like, it's kind of like the thought of, well, let me get the tissue valve now and I'm going to have fun and then they'll TAVR me later, right? But as it turns out, the valve and valve TAVR is not as good as it would have been if you'd just gotten the mechanical valve from the get-go. And I think we may be seeing the same thing about this. And we need to really understand and think about that. A lot of the younger people do really well with heart transplant. And while the significant, long-term survivors are in general going to be the younger people, especially those who have uncomplicated transplants, primary sternotomy transplant at 25, you're probably going to get 20 years out of that heart, right? Assuming that you don't have anything particularly wrong with you, you're not have a particularly aggressive immune system and, there's not other things going on. And granted, that only gets you to 45, but Jeff's point, is it any different if she would get you to 45 versus 50? Probably not. The other thing is that until the allocation system changes to prioritize patients who've had VAD for a long period of time, I think it's really unfair to ask people to commit to something that is not even a thing right now. And even if it does change, how do we know it's going to be a thing in 5 years? It may change to something different in 5 years. And again, they'll be deprioritized and orphaned by the allocation system. And I think that would be really horrible thing to do to people. And so the waters are very, very muddy around this. And yeah, I bet you could fill an entire podcast just discussing this and discussing recovery. I think recovery is exciting. Recovery is sexy. Recovery would be awesome. But I think we are nowhere near recovery on any meaningful way. And I agree. The Utah guys have put a lot of effort into it and they're very smart about it. But I don't think we have the right technology for recovery. the HeartMate 3 is not the right pump if you want to be getting recovery, right? There are medications that need to happen. Sure. Just unloading the left ventricle blandly and blanketly is not going to result in the left ventricle getting better. Now, how can I say this? Because I see it in the operating room. When you have a right ventricle or a left ventricle that's kind of struggling after a heart transplant, if you keep the heart empty and you say, okay, I'm going to rest the heart and it's going to be completely empty and it's just going to be beating empty, you can stay there for hours and that heart is not getting any better. And you're still coming out on ECMO and you're still coming out struggling. But half the time, that same heart, if you partially load it, have it doing a little bit of work, while the cardiopulmonary bypass machine is kind of correcting all the other metabolic derangements that are going on, and you're creating a milieu that's favorable for that heart to work, all of a sudden that heart starts to work. But it never, no matter how well you make the milieu, it never gets better just sitting there on their own beaten empty. And so I do think there is a lot of innovation that can happen around pump control, around LV chamber pressure monitoring, around all these things that if we actually cared about recovery, we would be, pushing and trying to figure out things to do. The other point is I have to say, I've probably explanted in my career 10 people, and at least half of them have gone back to needing another LVAD or a heart transplant after they're done. And to bounce back to the young person, one thing we could consider, and again, the driveline is the limitation here. One thing we could consider, especially if we had an implantable LVAD, is heart transplanting that patient. And then when that heart transplant fails, figuring out a way to put an LVAD in them on the back end. Because I bet we could potentially get a little bit more time out of them if we figured out a way to provide them mechanical support after transplant.
Yeah, I mean, and we're learning so much more about sort of the genetics of heart failure, particularly the non-ischemics, right? And just because the ventricle looks better in the short term, there may be sort of high risk variants that are just going to recur, right? Because that's what probably happens to a lot of the RVs over time for the non-ischemics, is that the myopathy progresses in their right ventricle that's unsupported. And so, it's a difficult question, but I think that the field is sort of super schizophrenic because you go to a meeting like the ISHLT and you go to one session, it's just this question, right? Should we be only putting MCS in young patients and, supporting them for 10 years and then transplanting them? And you go to the next session and it's like a gripe session of like, my patients with MCS can't get transplanted. It's like, well, if it's so awesome, why do they need to be transplanted? They're like, well, they can't be prioritized. They're not prioritized enough. I'm like, well, if it's so awesome, why should a person who's stable on a VAD be prioritized at all? So it's kind of weird. I think it's kind of, like I said, sort of a weird perspective on things, but it's certainly intriguing for kind of to move forward. And I think there's careers to be made trying to figure some of these questions out.
Again, I'm very much MCS oriented. I love heart transplant. Heart transplant is the reason I went into heart surgery, but it probably would be worthwhile if we spent, all this time that we spend, thinking about and figuring out investments we've done in recovery, if we shuttled that into improving MCS therapy. And unfortunately, it's so expensive to do this that we are at the mercy of companies and what interests them financially, right? When this field started, it was started by NIH dollars. It was started by a massive influx of money from the US government to solve this problem. Bud Frazier talks a lot about this, the days of Domingo Leota and Cooley and DeBakey and him. Like, there was a lot of this was a federal priority. It's not anymore. It's a commercial priority for some companies. But, honestly, I don't think it's a commercial priority for Abbott. Not to be saying anything negative about Abbott. Abbott has done a lot of work to help patients and make heart failure better. But, when they think about it, the population of LVADs hasn't grown, right? We're not putting in more LVADs. So it doesn't make financial sense for them to allocate millions and millions of hundreds of millions of dollars to developing more technology in the space if the space is not growing, if it's stagnant. And so, some of it comes back to us to really think about how are we going to move this forward? How are we going to help grow the space to incentivize players in the arena to help us with the technology?
Yeah, I totally agree. I mean, it still has way underpenetrated. There's still a lot of people out there. And, I moved to California and I take over a big transplant program and it was like, oh, I thought you were an MCS guy. Now you're a transplant guy. I was like, I'm not either. Like I do, you do what you do, but there's still a ton of people out there in terms of the Bay Area that need destination therapy that just don't get access to it because they're not referred here or they're referred too late. So I still think there's a huge disease awareness. And I think until we manage to tap into that, to Manny's point, and sort of see that population really grow, there's not going to be a huge investment by companies into the technology, unfortunately.
I cannot believe how amazing that discussion was. I cannot wait to listen back to this episode because I feel like there's just been so much knowledge dropped in the last hour or so. And I want to thank you, Dr. Teuteberg and Dr. Daneshmand, just for being with us today. Just to kind of wrap things up a little bit, I wondered if you maybe had one or two takeaways about LVADs and kind of what we talked about today that you'd like to share with the audience and the CardioNerds.
I want to reiterate one of Jeff's points, and that is somebody who's listening to this podcast is going to make huge inroads and impacts in this patient population. They're going to make an impact in recovery. They're going to make an impact in transplant. They're going to make an impact in VAD, either from a device human interface standpoint or a battery standpoint or something. And it could be you, right? So do it, think about it, spend your energy on it, and come up with, fixes for these problems that we've talked about. Because while Jeff and I are not at the end of our careers, we're also not at the beginning of our careers. And so as you get further down the road, a lot of other obstacles get placed in your way. And, it's not really until the end of your career when all those obstacles go away and you can go back to putting efforts into pure, development. That happens early in your career and late in your career. In the middle of the career, you're stuck with a bunch of stuff that distracts you from what I think is really the important, exciting parts of our field.
Yeah, no, I totally agree. I mean, it's sort of, speaking as someone who has more yesterdays than tomorrows in their careers, I think that one thing for these sorts of discussions is, if you're sort of listening and you're kind of just starting, is how many times we said we don't know, right? There's still just so many things that we don't know. And some of them are simple, just like long-term management, medical management of patients on VADs. Like there's just, like I said, there's careers to be made on this sort of thing, and just sort of listen to these sorts of conversations and hear where we say we don't know, and just start kind of peeling back the layers of the onion a little bit to see what's there, because there's so much more that we can do. And, maybe our patient selection doesn't get any better. Maybe our operative technique doesn't get any better. Maybe the technology doesn't advance by leaps and bounds. But if we can substantially iterate our post-operative care, our long-term management, and people are exercising better and feeling better and having fewer driveline infections, that's huge, right? And that can make the field move forward without any major change in technology. So I think that it's still an interesting field. There's not as many companies involved right now, but it's changing. And I think that you'll see that at ISHLT and other MCS meetings. There's a lot more entries into the field. So take advantage, chat with everybody, and, start off on something. And maybe it was in my retirement, as I'm sitting on a boat someplace, I can listen to you talk about sort of how you changed the world with MCS.
Thank you both so much for this conversation. A final question for both of you. Just, I guess, thinking personally about next steps for you, like what makes your heart flutter about this field and LVAD and kind of advanced therapies at large? We'd like to hear what you guys are really excited about to kind of end the conversation.
Yeah. So, I mean, I think the fact that there's still so many unanswered questions. I mean, I think fellows and residents and students come and say, there are issues with LVADs that still need answers. I'm like, oh my God, how much time do you have? There's so much. So I think that every field sort of has its fits and starts, right? And I think that there was a period of time a number of years ago when HVAD sort of left the scene, and it was just HeartMate 3 that people were like, oh, the field is stale. It's not going anywhere. And, maybe it was a little bit stale, but it's picking up again. But I would say the same thing, but when I came out of fellowship, all the energy was in mechanical circulatory support and none of it was in transplant. Whereas now there's a lot of really cool stuff happening in transplant. And I sort of always joke is like, transplants become sexy again. And everyone's like, transplant was never sexy to start with, so it can't be sexy again. But, there's a lot of cool stuff going on. And so I think that you just have to kind of ride the wave and it'll come back, right? The pendulum will swing back and there'll be more technologies, or there'll be something in the way we manage patients, or this, something in the way that how we approach heart failure that will really change things. Just don't listen to all sort of the doomsayers. I think there's still a lot of really cool stuff in the field. And so I think it still will be promising, for all of your guys' careers and more.
Yeah. I mean, I think Jeff has hit the nail on the head. And, what excites me the most about this field is you guys. You guys are the people who are listening to this podcast, the people who are doing this podcast. When I was a medical student, a resident, I would have killed to have something like this, right? To be sitting to this, to be able to talk to people about this, listen to this. And the fact that, this community exists means that our field is going to exist and it's going to grow. When I was deciding to become a heart surgeon and I was deciding to do this, everybody told me, oh, why are you doing that? This was the advent of stents and PCI and CABG was going down. I was like, why are you doing that? It's a dying field. There's no growth. Everyone's being fired. I had a couple of friends who were heart surgeons that quit and became, opened a coffee shop, And, I think what keeps the field alive and growing is young, interested, smart, energetic talent. And CardioNerds represents that. And I think that's what gets me excited, is that I know it's not going to die with me.
I'm not thinking a lot about death personally.
Not either. I want to see how I can get on your boat with you.
Yeah. I look forward to having you all on my boat.
Thank you both so much for, such insightful words and some kind words towards the CardioNerds at the end. We're so excited to have you both join us today. This was an excellent discussion. I certainly learned a lot, especially as I just started my VAD rotation today as the Heart Failure Fellow. So we appreciate the discussion, and thank you both so much again for your time.
Thank you guys so much. It was wonderful.
Thank you. This was lots of fun.
Thank you so much for tuning into this CardioNerds episode. The audio editing for this episode was performed by me, Joshua Khorsandi. I'm an intern in the CardioNerds Academy, House Taussig, and an undergraduate at the Johns Hopkins University. Check out the episode page for show notes and references. If you found this episode informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and splits.